Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 484 of our pharmacotherapy series, which majors in ischemic and hemorrhagic stroke. The first case reads, RBS is a 60-year-old, 5 feet 6 inches tall, 85-kilogram woman who is concerned about having a stroke. Her father died of a stroke, and her 85-year-old mother has had several episodes diagnosed as transient ischemic attacks, abbreviated as TIAs. RBS's blood pressure is 140 to 150 systolic, 90 to 100 diastolic, and she was recently diagnosed with diabetes mellitus. She does not have a history of transient ischemic attack or stroke. Additionally, she smoked for 25 years but has not used tobacco for the past 10 years. Her current medications include lisinopril, metformin, conjugated estrogen, medroxyprogesterone, and acetaminophen. She approaches her pharmacist because of concerns about having a stroke and being like her parents. So my first question to you reads, what can RBS do to reduce her risk of stroke? Any plan for primary prevention, i.e., prevention of a first event, of transient ischemic attack or stroke must address the control or reduction of risk factors. The reader is referred to a detailed discussion of treatment of diseases such as hypertension, diabetes, coronary artery disease, chronic kidney disease, etc. in their respective chapters. For RBS, hypertension is the most important and well-documented risk factor that requires immediate attention. 4. Adequate control of her blood pressure should reduce RBS's risk of stroke by 35% to 44%. On the basis of the 8th report of the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, abbreviated as JNC8, guidelines, RBS's blood pressure goal should be less than 140 systolic, 90 diastolic. Antihypertensives that have been associated with a stroke reduction risk are the angiotensin-converting enzyme inhibitor, hydrochlorothiazide, and calcium channel blockers. Because she is already receiving lisinopril and her blood pressure is poorly controlled, it is likely that a combination therapy is needed. The addition of hydrochlorothiazide 25 mg per day is advisable to RBS. Diabetes mellitus is another important risk factor for RBS. In older women, diabetes mellitus is a more significant risk factor for stroke than it is for men. There is controversy regarding the intensity of glucose control that optimally reduces stroke risk. Clearly, good control of diabetes mellitus results in better control of hypertension and other risk factors for stroke. Additionally, use of oral hypoglycemics may reduce the risk of stroke through mechanisms other than glycemic control. However, strict control of blood glucose did not reduce the risk of stroke over the course of 9 years in one study. There is evidence that angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers, abbreviated as ARBs, reduce the risk of stroke in diabetics, with or without hypertension. For diabetic patients with at least one additional risk factor for cardiovascular disease, taking a beta-hydroxy-beta-methylglutaryl coenzyme A reductase inhibitor appears to reduce the risk of stroke by approximately 24% even in the absence of hypercholesterolemia. It is known that beta-hydroxy-beta-methylglutaryl coenzyme A reductase inhibitors have anti-inflammatory activity that may influence the development of atherosclerotic plaques and cerebral ischemic processes. Because of these effects of beta-hydroxy-beta-methylglutaryl coenzyme A reductase inhibitors, these drugs should be started for primary prevention of ischemic stroke and transient ischemic attack even in patients who do not have dyslipidemia if the estimated 10-year risk of cardiovascular events is high, as recommended in the 2013 ACC/AHA guideline. Niacin, fibric acid derivatives, ezetimibe, or bile acid sequestrants can be considered for patients who do not tolerate HMG coenzyme A reductase inhibitors or have low high-density lipoprotein cholesterol concentrations. However, their efficacy in preventing a stroke is not established. The benefits of HMG coenzyme A reductase inhibitors appear to be a class effect, so selection of a specific agent should be based on the individual characteristics of the patient. For RBS, she should maintain tight control of her diabetes mellitus, continue her lisinopril, and start an coenzyme A reductase inhibitor, such as simvastatin or atorvastatin. The body mass index for RBS is 30.2 kg per meter squared, placing her in the obese category. Multiple large studies have demonstrated a direct relationship between increased body weight and an increased risk of stroke. There are no data available to establish the precise effect of weight reduction on reducing the risk of stroke. However, increasing physical activity and proper nutrition are essential to achieve weight loss and improve diabetes and blood pressure control. A diet high in sodium is associated with an increased risk in stroke, whereas a diet high in potassium appears to reduce the risk of stroke. Current recommendations for diet are for sodium intake of 2.3 grams per day or less and potassium intake of at least 4.7 grams per day. In addition, a DASH-style diet, which emphasizes fruits, vegetables, and low-fat dairy products and reduced saturated fat is recommended to lower blood pressure and thereby reduce the risk of stroke. Regarding physical activity, several studies have shown an inverse relationship between physical activity and risk of stroke. Therefore, at least 40 minutes per day of moderate intensity exercise is recommended 3 to 4 times per week. Cigarette smoking is an independent risk factor for stroke and potentiates other risk factors. In addition to active smoking, passive inhalation of cigarette smoke also appears to be a risk factor for stroke. Smoking cessation does result in a rapid reduction in the risk of stroke, but the risk never returns to levels seen in individuals who have never smoked. Finally, 5 studies have specifically investigated the effect of hormone replacement on stroke risk. On the basis of the results from these studies, RBS should discontinue her conjugated estrogen, medroxyprogesterone product, unless she is taking this medication for a specific reason other than control of menopausal symptoms or prevention of cardiovascular events. RBS should be encouraged to avoid passive smoke and to continue avoiding the use of tobacco. RBS should initiate a weight reduction program that includes a low sodium and high potassium diet with an exercise program. My next question to you reads: would RBS benefit from any antiplatelet or anticoagulation for the primary prevention of ischemic stroke and transient ischemic attacks? Aspirin has been carefully investigated for primary prevention of stroke. Although aspirin is recommended in the primary prevention of coronary heart disease, it is not generally recommended for the primary prevention of stroke or transient ischemic attack in low-risk patients, with 10-year risk greater than 10%. The use of aspirin for cardiovascular, including but not specific to stroke, prophylaxis is reasonable. A patient's 10-year risk can be calculated using online calculators such as http://my.americanheart.org/CVRISK calculator. In a study of 22,071 male physicians who took 325 milligrams of aspirin or placebo every other day for 5 years, stroke incidence was similar between groups. In addition, there was an increased risk of cerebrovascular events caused by hemorrhage in the aspirin group. Chen and colleagues reported a meta-analysis of 40,000 patients randomly assigned to aspirin and found a reduction from 47% to 45.8% in death and disability attributable to stroke. Another study considered the role of aspirin for primary stroke prevention in women. Women who took 1 to 6 tablets of aspirin per week had a slightly reduced risk of stroke and a lower risk of large artery occlusive disease, with a relative risk, 59%, a 95% confidence level, of 0.29 to 0.85, with a p-value equal to 0.01. An increased risk of stroke was seen in women who took more than 7 aspirin weekly, and an excess risk of subarachnoid hemorrhage was seen in those taking more than 15 aspirin a week. The Women's Health Study also investigated the use of 100 milligrams per day in asymptomatic women and followed them for 10 years, monitoring for non-fatal cardiovascular events including stroke. 0.46 in this study. There was a 17% reduction in the risk for all strokes and a 24% reduction in the risk for ischemic stroke, whereas there was a non-significant increase in the risk for hemorrhage. Women 65 years of age and older at entry into the trial showed the most consistent risk reduction, but hemorrhagic strokes negated some of the benefit. Additionally, women with a history of hypertension, hyperlipidemia, or diabetes, or a 10-year cardiovascular risk of at least 10% had the most benefit. There are very limited data currently available regarding the use of other antiplatelet drugs for primary prevention of stroke except for C-lostazole in patients with peripheral artery disease. Although oral anticoagulants are not generally considered safe for primary prevention of non-cardioembolic, patients with atrial fibrillation are candidates for primary prevention. These individuals are at risk for an embolic event arising from clot formation in the atrium of the heart. The CHADS-2 score has been a widely used system of stratifying the risk of thromboembolism in non-valvular atrial fibrillation for a decade. It is generally accepted that low-risk patients, CHADS-2 score equal to 0, should not be treated with anticoagulants but may be considered for antiplatelet therapy, while higher-risk patients, CHADS-2 score equal to or greater than 2, should be anticoagulated with oral anticoagulants such as warfarin, dabigatran, apixaban, rivaroxaban, or edoxaban. The tool recommended in the new guidelines, called CHA2DS2-VASC, also considers whether a patient has had prior vascular disease, evaluates people at younger ages, between 65 and 74, and factors in gender. This is important because women face higher stroke risks. CHA2DS2-VASC score of equal to or greater than 2 warrant the use of anticoagulants as first-line option. Numerous studies have clearly shown that warfarin prevents embolic cerebrovascular events for patients with valvular and non-valvular atrial fibrillation. In these studies, the warfarin dose was adjusted to maintain an international normalized ratio of 1.5 to 4.5, with most recommendations to adjust the dose for an international normalized ratio of 2 to 3. The selection of the antithrombotic agent depends on various factors including patient factors, risk of falls and hemorrhagic events, cost, age of the patient, tolerability, patient preference, and potential drug interactions. The stroke prevention in atrial fibrillation, abbreviated as SPAF, trial included aspirin combined with warfarin in one study arm and indicated that some benefit may be derived by combining antiplatelet agents with anticoagulants. A follow-up study was performed and showed no difference between warfarin and aspirin in preventing stroke in atrial fibrillation. In patients with non-valvular atrial fibrillation, aspirin can be used as an alternative to warfarin in patients with atrial fibrillation, based on the CHA-DS2 score or CHA2-DS2-VASC score. Additionally, warfarin may be used in primary prevention of embolic stroke because of a patent foramen ovale. For RBS, primary prevention of stroke with aspirin 81 mg per day can be considered because of her history of hypertension and diabetes mellitus. Given that she has no atrial fibrillation, she is not a candidate for anticoagulation therapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 485.